I am recording the first 5-minute clinical review. This is a patient, 19-year-old patient, who came into the emergency room with complaints of an ankle sprain. This is the information I had prior to going into the room. I knew that he had hurt his ankle 3 days before. He was an alert male, and they said that he was walking with a steady limping gait. Past medical history, they gave me a lot as far as back pain, diarrhea, heartburn. I did go through these, particularly the fact that he had an alcohol abuse. I wanted to know whether or not he had had prior injuries or if the alcohol was part of the contributing factors to the ankle sprain, obviously for safety. But today we're going to be focusing really in on the ankle. Social habits, no information entered. I did want to know specifically what medication, whether or not he used anything that would cause him to be more likely to have injuries. He did not use any medication. His vital signs were stable. So questions going on in my mind: how did it happen? How did he treat it? What things has he done? What things have been helpful? Has he continued to be able to work? Number one question I ask of people: can you walk on it? People can walk on a fibula fracture. They can't walk on a tibula fracture. What questions related to the history? Have you heard it before? Because when someone hurts an ankle, the ligament is overstretched. Usually they're going to hurt it again. The other thing is, how are they treating it? This gentleman happened to have an air gel splint at home that he was using, so he was doing the proper therapy. For the ankle injury, again, do you have pain up in the knee area? I'm thinking that you can have a higher fracture with a lower fracture. So with someone with an ankle injury, always check up on that proximal fibula. Can they feel their toes? Numbness, tingling, any other complaints? The anatomy, I want you to review this. There's 3 major ligaments that come across the ankle. And the much more likely injury is going to be right in this area. It's going to be on the outside or the lateral aspect of the ankle, usually in the anterior tibiofibular ligament. People can have it in all or just one. Here's the most common type of injury. It's going to be an inversion type sprain. I demonstrated this to people. My ligament is now lax enough that there's been a couple times where I've gone over where I've not injured my ankle because of it. But if you can see, it gets overstretched, has some tears in it, and that's where the injury comes from. First degree is probably those where there's just a little bit of pain, mild swelling, no bruising. This is usually someone just self-treats. Second degree, they're partially torn and bleeding. It's really hard to see the difference between a second degree and a third degree because of what the outside looks like. Usually by the time people come to you, they're pretty swollen. This is going to require immobilization. Here's an example. See how they were going to have black and blue here. The injury is here, but they will have black and blue. Particularly in a couple of days, this settles and they get black and blue in this area. Third degree, this is where you're actually going to have a complete disruption. Sometimes this might be difficult to see if the person has waited and there's lots of swelling, which causes a false sense of lack of laxity in the ligament. Generally, you can see this on x-ray, or if there's stress applied, you can feel the laxity. Again, the ligament breaks, so sometimes the bone does not. And here is an example. See how it does look very much like a second-degree sprain. Ottawa rules for actually getting x-rays. We're going to get them if there is pain over the posterior edge of the lateral malleolus, pain over the posterior edge of the tip of the medial malleolus, tenderness at the base of the 5th metacarpal or on the navicular bone. These are all the places that you need to touch because these are the ones that are going to help increase your questioning whether or not there's a fracture. The C, base of the 5th metatarsal, will tell you if you need to really look and get a foot x-ray. And here's an example right here. This is a fracture of the fibula. This is more important because from what I see, this is going right into the joint here, so I'd be concerned about that. And then this appears on this end really to have a little bit of instability because I'm kind of concerned about the increased distance right here. The acute treatment, first degree, is going to be rest, ice, elevate, maybe an ACE wrap. Second degree is going to require immobilization. Third degree, immobilization, crutches for second or third degree, and usually there may be a surgical intervention. Here are some treatment summaries based on evidence-based practice. Again, what they show is that people continue to have discomfort and that you really need to look at these over time. This is not something that's going to heal in just 2 weeks. That for second or third degree, that the person may have some complaints even a year later. This is your 5-minute update.